We're ready now. Thank you.
Good. Thank you so very much, and good morning, everybody. It's my pleasure today to talk to you about the early detection screen for dementia, which is an administrative rating tool that has been developed by the National Task Group on Intellectual Disabilities and Dementia Practices. As was mentioned, we go by the term NTG. So I'll just abbreviate that as we're going through. And I want to thank my sponsors for today for this ECHO session, the Administration for Community Living, Catholic Charities of Hawaii, and of course, the National Task Group. So one of the things that we found pretty early on, and our efforts began in 2010, was that we needed a way to help providers and healthcare practitioners understand and unpack what might be happening as individuals with intellectual and developmental disabilities age and might be showing decline or changes in cognition, behavior, or adaptive functioning. So one of the things that's particularly a problem, and those of you who are in the field of geriatrics know that it's not unique to people with intellectual and developmental disabilities, is this confusion among the 3 Ds. That is delirium, depression, and then, of course, dementia. So there are several conditions that mimic dementia, even when a person does not have Alzheimer's disease or any of the other forms of neurocognitive disorder. So it's really important to be able to observe changes and share that information with healthcare providers so that we can really get people the help they need, because some of the conditions that mimic dementia are in fact treatable and reversible. It's not actually neurocognitive disorder. So we want to have some way to begin to capture our observations of change so that we can distinguish among the 3 Ds, delirium, depression, which has sometimes been called pseudo-dementia, because individuals who in fact are very depressed very often look as if they are having dementing changes. And then the neurocognitive disorders that we broadly talk about as dementia. Indeed, there are many conditions that can affect adult functioning, and they may include psychiatric illness, sensory impairment, and exposure to extreme stressors, in which unless we really are on top of those observations, we may lose the opportunity or miss the opportunity to bring an individual to the attention of a physician or other healthcare provider to get the help that that person may need. So today's session is to really look at the tool, the NTG-EDSD, and explain the rationale for that tool, as I have begun doing, and to actually take a look at that tool with 2 case examples that I have developed for the purpose of our conversation this morning. So cognitive changes of aging with disability deserve attention, and why do they deserve attention? Well, memory problems, when they are significant, whatever the origin of those memory problems, interfere with everyday functioning. So a person is not able to work, they're not able to interact with others, they're not able to pursue daily tasks and routine to the same degree that they had if in fact their memory is a problem for them. Individuals who have cognitive changes may become disoriented to even familiar places and have issues with time, where they are located, or who they are, and it certainly would be the case if somebody has a neurocognitive disorder in end stages. So you can see how very disruptive the cognitive changes might be for somebody. It really affects quality of life and everyday functioning. We do see people slow down as they get older with disabilities, and that would include in their thinking and their processing of information. That can affect their performance in day-to-day activities or work. And then we may see such things as a coarsening of social behavior, meaning a person who characteristically did not have any issues about appropriate social behavior may begin to exhibit signs of difficulty in social settings. And so that is something that is part and parcel of what we can observe if somebody has dementia. And that's why we want to have a tool that helps family and professional caregivers begin to capture what they have noticed in changes in day-to-day functioning. We might notice that the person is increasing in impulsivity. Again, this comes from a knowledge of what is baseline and characteristic for the person. That's why family caregivers and professional caregivers who've been with the individual for at least 6 months are in a good position to inform a healthcare provider who's not going to know the day-to-day functioning of the individual and maybe would not recognize departures from that day-to-day functioning. One of the other things that we find is a person may have difficulty learning new information. So if they have a new task that they are expected to learn, or they have new staff supporting them, they may not be able to learn the name of a new staff member. They may call them by a person that they worked with years ago and not be able to process this new information. And of course, we do see changes in the ability to communicate, what has been generally termed an impoverishment of communication, where people, and now I'm talking about individuals who do have language abilities, that they lose their language ability, lose vocabulary, lose the ability to spontaneously generate conversations and respond to conversations generated by others. Problem solving can become a big issue for people. There is also a problem with pursuing well-learned routines and activities, and confusion in familiar places. I mean, people do not randomly become confused in a familiar setting, their home setting or their work setting where they've been for a while, but you may find that people do begin to show these signs. So these are what we're looking at, and this is what deserves attention. So what is a neurocognitive disorder? It is a brain disease that affects all domains of functioning. So I know that we commonly hyper-focus on memory. Actually, memory is not the only skill that is impacted if somebody has a neurocognitive disorder like Alzheimer's disease or multi-infarct dementia. And you will see changes in social behavior. You may see behavioral changes that we term behavioral and psychological symptoms of dementia. And of course, adaptive functioning can change. And this, we're talking about changes over and above the challenges the person might have by virtue of having an intellectual or developmental disability. This is not baseline and characteristic for them. So what do we mean by cognitive skills? We mean changes in memory, attention, problem solving, perception, and the use of language. Social skills, such as understanding one's own behavior and that of others. Behavioral skills such as self-control, emotional reaction that is appropriate in settings and situations. And adaptive skills are activities of daily living, the ability to dress oneself, toilet oneself, feed oneself, and be independent in ambulation. Individuals with pre-existing cognitive challenges, such as individuals with intellectual and developmental disabilities, are more likely to display an early onset if they have neurocognitive disorder. So I want to say a proviso about that. I am by no means suggesting that most individuals with intellectual and developmental disabilities go on to develop dementia. That is not the case. However, we do know that if they do develop a neurocognitive disorder, what we're calling dementia, it tends to be at an earlier age than their peers without an intellectual or developmental disability. And we know individuals with Down syndrome are at particular risk. For instance, the average age of developing Alzheimer's disease or known Alzheimer's disease for individuals with Down syndrome is about age 52. So again, it's considered an early onset dementia because in the general geriatric population, you don't tend to see these changes until several decades later, characteristically. So the problem that we have is we have a hard time catching up with how the brain changes. We know that the brain itself changes. It changes in structure. And that is likely to precede our awareness clinically that the person is showing signs of dementia, like Alzheimer's disease, which is the most common form of dementia, by more than 1 to 2 decades. So we're really saying that our brains are changing, or the brains of an individual whom we're concerned about with intellectual developmental disability will be possibly changing 20 years before we actually see signs in day-to-day life that they are impacted by cognitive decline. So, of course, the earlier we can identify changes, even if it is to rule out, there are many things that may affect adaptive skills for adults. So, you know, even if we are ruling out that it's not likely to be neurocognitive disorder, it's likely to be something else, we are really best supporting, that's best practice and support of individuals as they age with an intellectual and developmental disability. The earlier we can identify, we have the greater potential to proactively address signs and symptoms of change. Intervention services and supports are going to be more effective if offered prior to significant cognitive, behavioral, and functional changes. We don't want to wait until the person shows evidence of significant decline before we activate ourselves in terms of providing necessary supports. So early identification of signs and symptoms is an important first step in managing the course of what is a disease or is a course of a condition that is going to impact multiple, if not all, areas of the individual if they have neurocognitive disorder. And it helps us provide quality care. The family and the professional caregiver can work with the individual's healthcare provider to share information about observed changes. So here I'm going to give you again my sales pitch for the use of the National Task Group Early Detection Screen for Dementia, the NTG-EDSD, which is not a screen to diagnose dementia. It is a screen, an administrative tool to notice early changes that may be associated with neurocognitive disorder, but we want to capture that information about early change as soon as possible in areas of adaptive skills, behavior, and cognition. So again, the benefits of early identification of change is that it can lead to proper targeted care and affords a greater chance of benefiting from existing treatment. We don't want to be behind the 8 ball. We're already behind the 8 ball because brain changes have occurred before we're actually able to detect them clinically. An early diagnosis can help ease anxiety that may accompany unexplainable changes in behavior. At least you know what you're dealing with, right? Educating persons with dementia and their caregivers gives them time for advanced planning. That is something that will be necessary if an individual has a neurocognitive disorder. Very often it is years in progressing, so that you're having to make plans for how the changing needs of the individual evolves. What does that mean in terms of how to support a person over time? And quality of life for persons with dementia and their family can be maximized. And again, that goes back to planning, getting the necessary resources in place to help both the individual and the people who support that individual. Of course, it is complicated to really recognize neurocognitive disorder if you have an intellectual or developmental disability, because many of the individuals with IDD, intellectual developmental disability, already have cognitive impairment. So unless we have a baseline in understanding how the person functions, it's very difficult to know if the changes we observe are significant enough to constitute a concern or support our concern about a neurocognitive disorder. Behavior disorders and poor emotional control can also complicate recognizing early signs of dementia. We really don't, in fact, have any consensus about a tool that can directly assess if an individual with intellectual and developmental disabilities has a neurocognitive disorder. In the general geriatric population, there have been batteries developed. Very commonly, we use the dementia rating scale as a way of kind of staging where a person may be in cognitive decline. But a tool like that, as well as the other tools that have been developed, presume average intellectual functioning. We really do not have a tool that we can agree upon that can be used. Many clinicians I've used it, the severe impairment battery, but we have to do some more testing to determine whether or not that tool can be standardly applied to people. And the other issue is that we have people at varying levels of intellectual disability. So it may make a difference if you are severely or moderately intellectually disabled versus if you're mildly disabled. If you are mildly disabled, you're more likely to still have language skills. And whereas at the lower end of moderate, severe, and certainly profound intellectual disability, you may not have language skills, which makes assessment of something like neurocognitive disorder very, very difficult. Now I'm speaking, putting on my psychologist hat as an assessor and somebody who's been involved in evaluating people for many years. So pre-existing level of intellectual ability, sensory impairment, and health status may all impact upon an individual's cognitive and functional status. In other words, there may be many things that affect an older person or a person as they're aging with a disability that impact on their performance that have nothing to do with neurocognitive disorder. That's why it's important for us to observe change and to bring people in a timely way to attention so that we can begin to track this more effectively. So things to know about dementia, okay? One of the things is to know is dementia, although I've been using dementia throughout this presentation and will continue to do so because that is the term that is usually used. Dementia itself is not a diagnosis. It's an umbrella term that is applied to a number of neurocognitive disorders, the most common of which is Alzheimer's disease. There are other forms of neurocognitive disorder, as we'll see very soon. But it is, an umbrella term to signify a person is no longer functioning at their own characteristic baseline. And that's why it is so important to know what is characteristic and what is baseline for a person, because otherwise we won't know whether change is significant or not. And again, we're talking about understanding changes in behavior, cognition, emotional control, and adaptive functioning. Notice I am not hyper-focusing on memory, because memory is not the only way in which we see a signal for neurocognitive disorder. Alzheimer's disease is the most common form. We did mention that people with Down syndrome have an average age of onset of Alzheimer's disease of 52, whereas for individuals without Down syndrome, it's not necessarily clear that they are at risk as of age 50 or older. We do tend to see people with IDD, that is non-Down syndrome, in their 60s that show cognitive change, which is similar to the geriatric population. Changes in personality and behavior often predate memory changes. So one of the things I would find when I did evaluations early on is families would come to me and they weren't complaining that their relative had memory issues. They were saying, you know what, Joe is just not Joe. He's not behaving the way Joe always behaves. He was such a sweet and gentle and cooperative individual, and now he's combative and he's irritable, and his style is just different. He's just not acting like Joe. So again, in our population, we might see personality changes predate our recognition of any memory or other cognitive issues. Progressive decline can last if you have neurocognitive disorder, typically from 1 to 7 years if you have Down syndrome. But I've known people who have been dealing with a neurocognitive disorder for over a decade. So again, it's a highly individualized condition, a lot to do with what you bring into the situation in terms of resources, reserves, etc. But indeed, it is very variable. But some people rapidly progress. We hear reports from families that individuals with Down syndrome, once they have the diagnosis, rapidly progress. But there is tremendous variation. But we do know that as the disease progresses, there will be increased need for care of the individual because memory, self-care, communication, ambulation, activities of daily living will all be impacted, so that personal care needs will increase. And here we have this umbrella icon or picture indicating that dementia itself is not a diagnosis, but a way of talking about or framing a number of neurocognitive disorders, Alzheimer's disease being the most prevalent, vascular dementia, cerebral vascular, or multi-infarct dementia, those are all terms for vascular dementia, or frontal temporal dementia. We are first beginning to learn more about how our population, people that we work with, are impacted by other forms of dementia than Alzheimer's disease, and we don't have quite the statistics we need for me to make a compelling case about that. But needless to say, we do have some of our clients, the people that we work with, do experience other forms of dementia. Sometimes they have mixed dementia with Alzheimer's and Parkinson's disease, or Alzheimer's and vascular dementia combined. This is a picture of two brains. The brain on the right side of your screen is one that has been impacted by Alzheimer's disease, and the one on the left is a so-called normal or typical brain that has not been impacted. And you'll notice that the actual size of your brain shrinks, and that you'll notice there are large gaping holes, which we call sulci, whereas in the normal brain, your convolutions in the cortex are pretty tightly packed. What this all means is that your brain is less effective, less efficient in processing information and communication between brain cells when you're impacted by Alzheimer's disease and other forms of neurocognitive disorder. Your brain actually changes, and that's the reason. So let's, think about the warning signs of dementia. There are unexpected memory problems, getting lost or misdirected in a familiar setting, problems with gait or walking because it is a neurological condition. All the neurodegenerative neurocognitive diseases are neurological, and it is not unusual for walking or ambulation to be impacted. You may see an onset of new seizures every time the brain is impacted in some way in its structure or shape, its size, or if there are lesions. You have the possibility of seizures activity. And for some people who had seizures when they were children but have not had seizures during their adulthood, you may see the reemergence of seizure activity. If the individual may be confused in a familiar situation whereby customary tasks at home or at work become more challenging for them. They don't know how to sequence a certain tasks that they've done for many, many years. Things that were customary and routine are now difficult to accomplish. Again, changes in personality and difficulty maintaining social connections with family and friends. Not that the person doesn't want those connections, it's that they are not able to initiate or sustain those connections on their own. So reduced work performance, difficulty with recent memory and new learning, changes in communication, and emotional lability. I'm going to begin kind of going through a little bit more rapidly because I want to actually get to pull up at least one example of a completed NTG-EDSD. So first steps is when you observe a change of thinking, mood, or behavior that's significantly different and has lasted more than 2 weeks, and you know the person does not have a psychiatric illness, it's not a mental health issue that may be driving it, you want to make an appointment with the primary care physician and begin advocating for what you have seen as changes in this person's functioning. You begin the dialogue, and the EDSD can be very helpful in you having that dialogue with a healthcare practitioner. So this all began, we all got, our enterprise with the National Task Group began really with the national plan to address Alzheimer's disease. Each state has its version. The state of Hawaii has its version in which the 5 goals of the National Alzheimer's Project Act is reflected. The act itself came out in 2011. We actually began forming in 2010 in anticipation of this, wanting to make sure that people with IDD were adequately represented by the national plan and how to enact the national plan. So some of the goals is to prevent and effectively treat Alzheimer's disease by 2025, optimize care quality and efficiency, expand support for people with Alzheimer's disease and their families, enhance public awareness and engagement, and track progress and drive improvement. So that was our rationale to kind of get in motion, and we recognized pretty early on we needed a way to help family and professional caregivers, DSPs, you know, the staff that work with many of the individuals when family is not providing support. We needed to give them some way of summarizing what they were observing so they can share it in some coherent way with healthcare providers. So this tool is also a way to train everyone to become a better observer about what may be involved in changes associated with neurocognitive disorder. Again, it is an administrative tool. It's a tool that allows you to make certain decisions as a team. It is not meant to diagnose dementia as such. Very clear about that. This is what the FACE page looks like. It's based on Shamitra Deb. His work, he's a British psychiatrist. And then we did an adaptation in 2010 based on Philadelphia Coordinated Healthcare Group. That tool was the D-SQUID that Shamitra Deb had developed and that the Philadelphia group modified, and we did a further modification. So I guess we're the 3rd generation of this tool. And we piloted it in 2012 internationally. Our recommendations are that individuals with Down syndrome be baselined with this beginning at age 35. And that's because we want an adequate time to baseline behavior before we know they enter a high-risk category at age 50 or and beyond. And then annually you would use the tool, maybe as part of a wellness visit and checkup, to kind of share with the healthcare provider what you have seen. If it's people without Down syndrome, no reason to believe we can't wait till after 50 to begin baselining, with the idea that they're probably not entering more of a risk area until their 60s. This tool is being used internationally. It's actually used by the Down Syndrome Association in Scotland for all of its clients. So some things with the use, again, not for diagnosis. You know, I say this all the time and I still am asked about this. This is not a diagnostic tool. You do not have to have the person with you when you're doing the rating, but it has to be somebody who knows the individual. It has to be somebody, either a family member and or a staff person who's at least worked with the person in question for 6 months or longer, right? And this is meant to kind of capture early change. So what's the role of family and professional caregivers in this? That you are actually going to complete this assessment. It's a Likert scale. You're going to see it in just a few minutes. And you can do it either pen and paper, or you could do it online, or there is a version that's an electronic version, and it converts into a PDF. This is meant for your information, for the information of the family or professional caregiver. You do not have to share this with anybody else, but it is meant to help you capture, so it's not just anecdotal, but actually what you have observed with the healthcare provider so that you can move things along. And then, you know, if the person attends a day program or is working, or there are multiple settings, you may want to have the staff from multiple settings and family members fill out the form. Sometimes we get different results depending on the setting, because the different task demands that are placed on the individual depending on the setting. So they may, the person may have difficulties in one setting and not in the other, and that becomes important to know. We want to make sure that certain things are ruled out, like delirium and depression, which is commonly, and sensory problems, commonly mistaken for dementia. And so it is not true that every time an adult has adaptive problems, whether it is cognitive, behavioral, or in their ADLs, that it is because of dementia. There are many things that may impact upon adult functioning. We're just looking to try to tease out so we know what to do. The EDSD looks at behavior, personality, memory, activities of daily living, and sleep patterns. These are all areas we know are also implicated with dementia. We are looking to baseline. So what is the person? How are they functioning now? So we have a picture in time against which to compare any future changes should they occur, okay? You look for patterns. What do you do with that? Look for patterns. What are the area of changes that you've noted? Is something being done to currently address this issue? Bring it to the team to brainstorm options, develop an action plan, share with everybody, evaluate the effectiveness of your plan. This is information, a way to collect information. Very important to share findings with members of an interdisciplinary team. So, you know, that's the only way that you can have a plan across settings and across shifts and across staff that may support, and across caregivers that will help the individual, okay? And again, we're going to be looking to have conversations with healthcare providers about this so we can reach some shared decisions about how to proceed. So what are the types of decisions that have been made? On the basis of information from the EDSD, the team may recommend modifications of the person's residence or a change in residence because the level of supervision and support might need to be altered. A change in staffing support, the way staff is deployed with the individual. Changes in program expectations or task analyses and how to help the person function best in their usual activities. It might be developing a positive daily routine that includes certain things that the person automatically did, but now needs prompts and reminders, and to have someone help structure it for them. And identifying items and activities for mental and social stimulation. It promotes time-sensitive intervention and support. Again, you want to share this information. Healthcare providers are highly dependent upon what you share with them. If you are a physician, a nurse, any healthcare, even as myself as a psychologist, I am seeing this person in front of me for one session of something. I don't see them on a day-to-day basis. I am dependent on collateral information that comes to me from the people who know this person best. That's the best way to get care for an individual. And what does the person need in order to be safe? It may be that you need to increase, the person may begin walking out into the street, walking into traffic, being disoriented, lose their way, elope, wander. You have to, build in some safety precautions that were not possible or necessary. That wasn't possible, wasn't necessary before because the person was independent and didn't need that kind of assistance. We're going to rule out other factors and the healthcare provider may say, you know what, we need further testing. I hope that's what the healthcare provider is going to say, and not just kind of on the basis of looking at somebody one shot, decide whether or not the person has dementia, because in fact there should be lab findings, there should be a direct assessment. It is really pretty complicated to actually come up with an accurate diagnosis of dementia, particularly with Alzheimer's disease, multi-infarct dementia. So here's some, I hope with your access to a PowerPoint, you would look at some of these websites, and these links are very informative. You'll see on it the AADMD.org and the NTG page where you can obtain a copy of the NTG-EDSD as well as other important information regarding support of individuals with IDD and dementia. So what I'm going to do, because I'm not ready for questions yet, is I am going to pull up, and we have time to at least review one of our, so let's see if we're going to go with David. So hopefully you can see, this is the NTG-EDS cover page. It's a 6-page rating form. It takes about 15 to 20 minutes to complete this tool. It is very straightforward, or the attempt is to be very straightforward. So a lot of the questions are for your reference only. This is for your reference, like file number. If you have a number of people whom you are doing an assessments for, baseline assessments, you probably want to have some system to organize this, to quickly retrieve it. So I'm saying that we're doing an assessment of David. He was born on June 1st, 1963. He's 57. And it'll ask you for the sex of the individual, the gender, he's male, and his best description of level of intellectual disability. Well, he has previously been assessed with mild intellectual disability, meaning from 55 to 69 full scale IQ. Very often you may not know the last assessed IQ for the individual. For many individuals who are older, they have not been tested for years, maybe since the time they were in school or maybe even before that. So if you know it, it can be helpful. It is helpful if you know what their developmental disorder is. The most common form of developmental disorder is just intellectual disability. But for instance, we're saying that David, for the purpose of this eval, has Down syndrome. He lives alone. I'm sorry, let's take that. Well, I can't, but he lives in a community setting. He is in what we call in California supported living situation, where he's in his own apartment, but he receives support from an organization. General characterization of his current health, that's item 10, is good. He hasn't had any major problems during this year that he's been evaluated. 11, compared to last year, though, it's somewhat worse. He didn't have any major events, but apparently the staff is saying that if you look at his, medical status compared to, and again, this is subjective. The person filling this out is a staff person. They're not rendering any kind of medical opinion about their physical status, but just saying generally there's been perhaps somewhat worse as a decline. If I was reviewing this with them, I would say, you noted that there's been a decline, somewhat worse. Could you tell me what's different compared to last time you filled this out? I might find out it's a different person who's completing it this year than last year, and that therefore their opinion that it's worse might, I don't know what it's based on. Or it may be the same person, I would hope, and then they can provide me with the information about why they rated it as somewhat worse. Item 12 is, compared to 1 year ago, what about the mental health? Again, this is a subjective question. It is not something that is being asked of somebody who has any mental health or medical training. And again, they said somewhat worse. That would prompt me, when I review the form with them, to say, well, what do you mean by that? Could you give me an indication of what you mean? Right. 13, we're looking at conditions that are present. And the staff person has checked off vision is corrected by glasses and hearing is corrected by hearing aids. So we know the person has some sensory changes, and I don't know how long they've had hearing aid or glasses, but I might inquire about that because sometimes that will affect how a person functions. 14, any significant events, because we know extreme psychosocial stressors can impair the functioning or impact upon the functioning of a person. Well, they've had the death of someone close, and it actually was a significant other that David had, his significant other died within the year of this eval being done or this screening being done. Changes in staff close to the person. He's also had significant changes in staffing. Another thing that we would be curious about if we're reviewing this rating scale with staff, because very often that will impact on somebody's functioning. We find out that he has no history of seizures. Now, this may be something that will change in subsequent ratings. But right now, no history of seizures. In other words, no seizure activity. And he was previously in 2016 diagnosed with mild cognitive impairment. He was by another psychologist, not myself, who indicated on the basis of testing that he did with this individual that in fact he had some changes in at least one area of cognition. We know that a certain percentage of people who have mild cognitive impairment go on to develop dementia, and a certain percentage do not. They just plateau at having one area in which they are showing. So very often it's attention problems, tracking and attention problems. And then, actually it showed us what this psychologist used in order to arrive at the mild cognitive impairment classification. He used the severe impairment battery, which is one of the testings I mentioned have been used by some clinicians. His own observations of this individual, and then collateral information from staff or family. And comments about suspicions is he was less productive at work, previously very particular about keeping his apartment clean, but now less interested in engaging in any of those activities. And he has stopped attending social activities that are sponsored by the agency. So he was somebody who was quite social, and now he is beginning to withdraw from some of those activities, which represents a change that we want to be monitoring and looking at. So now we have the Likert scale that I have been referring to, and I'm going to quickly go through this because I want to leave some time for us to be able to have question and answer. And you will see it's always been the case, always but worse, new symptom, or does not apply. Actually, the outside two categories are the least informative. So if it's always been the case that somebody's had a problem, then, you know, okay, well, we're expecting that to continue. If it does not apply, it means the person doesn't have a problem in this area. It's the inside two columns that are the most informative. So if the person has always had a problem in this area, but it's gotten worse, it's something we want to pay attention to and track if it is a brand new symptom within the past year. So you'll notice he's now incontinent where he previously was not. He now has difficulty finding words where previously he did not. He appears to get lost in the middle of the conversation, which was previously not a problem. He wakes up at night, there's inadequate sleep, he's confused at night, and he wanders at night. These are all indications that there has been a significant change in his functioning. Now, I don't know that dementia is the reason for it, but I would want to be tracking these symptoms, so to speak, or these signs very closely. And he has had several falls. And that's another area that we want to, again, balance may be affected, or he may have depth perception problems contributing to this. So I want to find out more about that. You'll notice we have memory later on. It's because people use memory as the go-to thing as if it's the only thing happening. But in fact, memory is only one of the many areas impacted. You'll see there are new symptoms there. Under behavior and affect, another big category, there are new symptoms here. And then he's reported some things about changes that he's observed, and that is captured in item 25, in which he has said changes in ability to do things, and he has reported changes in his own memory. There have been changes in his gait, which probably have contributed to his falls. On page 5, we are including something that is used by the University of Illinois at Chicago, which is just a listing of chronic health conditions, because we're wanting to help track if there is any coincidence of health conditions and dementia. Of course, we know, for instance, heart problems, hypertension, stroke, anything that diabetes puts you at risk for stroke, also puts you at risk for cerebral vascular or multi-infarct dementia. So you'll see several things have been tracked off there. On page 6, which is the final page of the EDSD, they have attached, and actually this would come from my review, treatment of chronic conditions, and there are mental health conditions as well. There is no treatment for pain for this individual. So we don't know if he has sleep apnea, never had him evaluated by the sleep center. That was one concern or question. We don't know if he has dementia. We're hoping you will help us figure this out. That was their other comment in their referral. You know, so the next steps that I came up with is refer to the physician, included an annual review or their annual wellness visit, and let's repeat this every 6 months because he's already shown significant changes that would lead me to think if it's not dementia, then if something else is going on that we really need to pay attention to really soon, because there were several new signs or symptoms that were reported by the supported living staff. So that's it. You know, it's meant to help you have a dialogue with healthcare within your teams and with healthcare providers. So now I'm going to be exiting and opening this up for conversation, you know, with the rest of you about this. Any questions or comments?
Thank you so much, Dr. Esralew. I wanted to ask before the questions, Jennifer Ernst, who's here with us from Special Olympics, who is the Healthy Communities Manager. Jennifer, could you share a bit of why you think this issue is important and how you are championing this with the Special Olympics?
Sure. We've noticed that a lot of our athletes are aging, and fortunately they're staying with our program, which is great news. But we have a health component with Special Olympics, and we really want to be able to provide our parents and caregivers and their siblings the information about this tool. We recognize the importance of doing the baseline information gathering, and we also want to be able to provide our families with resources in Hawaii if they should identify anything and they need more information. So we're working together with you folks to share the information, webinars, presentations like this, to get that information out there. And we're kind of trying to think of a way that we can facilitate that through maybe our Healthy Athlete program or a leadership conference coming up in the future.
Have you noticed anecdotally these changes happening in some of your athletes?
Yeah, we have. I know that a lot of our coaches have mentioned things that their athletes aren't able to participate in some of the sports that they had before. And I have personally with some of my favorite athletes, and so it's important for me personally to get the information out to folks that can help the families dynamics, because our parents are getting older too, and they may want to take this similar test. But yeah, it's, we care for our families, not just our athletes, but our families and the whole support system. So we really would like just folks to not fear that taking this test with your athlete at home, your person at home, is going to diagnose Alzheimer's. It's a great way to get to know the person and get to know should there be a change, and a great way to be able to bring this to the healthcare provider.
So you're really being a change agent in Hawaii, and that's what we need, because we're trying to launch to expand usage of EDSD. So any of you that are logged in today, we really invite you to join us in this quest, which means banding together, you know, all the agencies and the state and everybody to understand what it is, and also doctor education. Dr. Fernandez, I know you're on the phone. I don't know if you want to say anything. Okay. Oh, maybe.
Well, we're very happy that a lot of the doctors in Waipahu who attended our initial training on the EDSD, and we're looking forward to training more doctors who have most of the DD-ID population here on the islands.
That's great. Dr. Rita Bell Fernandez is a geriatrician who's been involved in our dementia grants, and she started memory clinics in different community health centers. So we're very lucky to have her there as an advocate for this, and she does the NTG training for us. So if any of the agencies want her to do the training, let us know. She's very, very good. Her presentation is wonderful. So does anybody else have any questions today, or wants to chat a question in? I know we're right at 11 o'clock. I'm not hearing anyone. This was great because we were able to record. And so I'll be sending an archive of this recording that you can forward to anyone, the link. And unless a chat question comes in or we get another question on the phone, we'll try to stick to schedule. The most important thing was to catch Dr. Esralew when she's in town and get this archive today. But also we're giving a live presentation tomorrow at the ARC in Hawaii at Diamond Head location. For anyone that wants to attend in person, Dr. Esralew will go over the same stuff for a little bit longer tomorrow with the ARC. You can contact me. Again, the easiest thing is give you my phone number on Oahu. If you're on the phone, it's 295-2624. We really appreciate all of you being here today, and we'll let you know about webinars coming up on all kinds of topics having to do with brain health, intellectual and developmental disabilities, and dementia. It's kind of exciting. We'll keep you in the loop. But thank you for being here today. We'll end right now and stop the recording.